So can you see?
Perfect. All right, we can get started then. It's not get working for me, but let's try that again.
So Moni, are you okay? Are you seeing it? You are now on.
Great. Okay, we have a packed agenda today, so we are going to get started. Hello, everyone. Thank you for joining. Thank you for listening as we troubleshoot the translation. I think everything is working well now. For those of you who don't know me, my name is Sam Dolan. I'm a program officer at the Gates Foundation and oversee our mortality surveillance portfolio, including our sample registration system work. This is the third of our public-facing webinars on planning for a SRS. And so today's topic is resource mobilization. Just as a reminder, all of the recordings and the slides will be distributed after the call. I will shortly put all of the slides in the chat, the updated slides, for you to follow along if you're having any connectivity issues. We have a packed agenda today. We're going to hear from Africa CDC. I believe I saw Emily's joined us to talk about their, they have some training materials on how to go about resource mobilization to support mortality surveillance. Then we're going to hear from Dr. Ivalda about Mozambique's experience with obtaining global fund as well as other funding streams to support their sample registration system, followed by Dr. Stephen from Zambia, who will talk about their experience gathering multiple co-funders to support their sample registration system. Then we'll hear from Dr. Philip from the Vital Strategies perspective and experience with obtaining global fund funding to support SRS-VS strengthening activities. And then finally, we'll hear from Dr. Daniel on the funder landscaping tool that you all can use to kind of help support your planning for resource mobilization activities. And then finally, I have a couple of just reminders and announcements at the end that we will hopefully have time to get through. Given our short time here together today, I am going to remind presenters if you are getting close to your allotted time amount. So just apologies in advance if I seem a bit rude and ask for you to speed up. But that's all from me, and I think I can hand it over to Emily to start us off with Africa CDC's overview on research mobilization.
Thank you very much, Sam. Good morning, good afternoon, colleagues on the call. So quickly, I'm just going to share with us a brief overview of the current funding landscape on the continent, particularly the policy direction, given the current environment we are in. And then with that, I will then narrow down into the resource mobilization course that we developed a few years ago at Africa CDC, devoted to mortality surveillance program development for the Africa Union member states. So to start with, we all are aware of the global trends in terms of official development assistance. And in Africa, this has, has not been a new turn of events, as it has been observed that since around 2021, there has been an increasing decline in official development assistance. And definitely, this has impacted on Africa's health systems as they continually face the pressure of limited financing and impacting on the service delivery for universal healthcare access. So with this unprecedented trend, the continent actually risks losing not only the health gains that have been made with hard efforts over the past decades, but there is also a looming failure to meet the SDG 3 target by 2030. Currently, the continent is struggling with the surging external debt, which further shrinks the resources for the already limited domestic investments in health. On the other hand, we know that there is an increasing trend of public health emergencies that also exert pressure on the health systems, and these are of a a varied range of factors, both human and environmental factors. We also are aware that in this era of searching information and technological advances, this has not very well reflected in the African continent, particularly in the health information systems that remain mostly partially digitized, or in some cases not digitized at all, limiting availability of timely information for public health actions. So if you move to the next slide. So with, with that brief background, I just wanted to sort of show a continental policy perspective on how things are evolving in terms of the policy direction and decisions regarding health financing and resource mobilization for health systems. So in February 2024, the African heads of state and government endorsed the Lusaka Agenda, which is actually an African-led strategy that defines strategic shifts aiming at advancing and alignment of external support with national plans and budgets, but also promoting the increased domestic resource allocation to health sector by accelerating implementation of the Abuja Declaration that is an earlier policy declaration that called for at least a target of 15%.
Sorry, Emily, can you unmute yourself?
I am sorry. What happened?
You were just muted for the last like 30 seconds.
I don't know. Okay, sorry. So where did you stop hearing me?
At the target of 15%, I believe, health budget allocation.
All right, so if I can just briefly summarize this slide. The African heads of state of government have endorsed a continental strategy for health financing, which is referred to as the Lusaka Declaration, and it emphasizes alignment of external support with national budgets and plans, and also promotes or emphasizes increased domestic resource allocation in line with the Abuja Declaration that called for allocation of at least 15% of national budgets to health. So in light of the rapidly changing landscape of external financing, Africa CDC has proposed a multi-pronged strategy for resource mobilization aimed at supporting the building of resilient and self-sustaining health systems. And so this strategy is composed in a concept note, a concept paper that has been published. It can be found on the Africa CDC website, and it addresses itself to three main pillars, focusing on domestic financing, innovative financing, as well as blended financing. So with that background, I will now go back to the focus of our meeting today, where I am meant to shed light on the Africa CDC's resource mobilization training program that we developed way back in 2019. And we ran two cohorts of training, one being in 2019 and another being in 2022. So the aim of this training program essentially is to build capacity for Africa Union member states to develop robust proposals for their national mortality surveillance programs. And the other aspect of the capacity building is to grow and strengthen the platform for networking between the funders and the member states or the entities across the continent that are looking to support or implement mortality surveillance programs. So in this online training, we developed a package of training materials and fundraising resources that we shared in 4 Africa Union languages. And this training program is actually available on our learning platform, although not open access because it was designed to be delivered with the assistance of facilitators. So it has a 6-module pack, and it is delivered in sessions lasting at least 3 hours each session. And from the sessions, we gather feedback from participants to identify areas for additional tailored workshops to support individual countries to be able to successfully develop their proposals and submit them for funding. And this is both ways. It can be the domestic or internal funds or external funding, depending on where they are looking. It also contains the one-to-one support through a dedicated helpline. We do set up sort of a help desk where we create office hours to liaise with the participants and be able to offer them some expert advice. We gather together experts who are seasoned and have a good understanding of fundraising and what it takes to develop proposals and navigate the whole process of mobilizing for resources. So in a way, this is the overall picture of how the course was designed. So if you move to the next slide. Yes. So the course has 6 key modules, and these specifically take the trainers through aspects of resource mobilization, what it entails, donor identification and engagement, how to plan and develop your proposal until the point of proposal submission, and also have a clear plan of how all of these steps are navigated, but also should the funding come through, what would the implementation and the M&E look like? So in terms of course delivery, we deliver this course through, first of all, enrollment is by official nomination from member states. The reason we designed it this way is because we wanted to be able to build capacity that feeds into national priorities and not necessarily individual researchers who are seeking to mobilize funds for their own personal interests. So that is why we restricted it to official nominations from national governments. And so it is designed as a hybrid course. It combines aspects of both virtual and in-person sessions. So we take participants through the first 4 modules, and by the 4th module, we identify those that should be able to proceed with the remaining modules. We take them into an in-person training where we work with each team's hands-on to panel beat and finalize their proposals to a level that is worth sharing out with their intended partners. Next slide.
Emily, I'm going to ask if you can wrap it up in 1 minute since we're getting a little bit close to time. Thank you.
Sure. So what are some of the success stories we saw during the 2 cohorts of training that we conducted? In total, we trained 25 countries, and of these, we saw 4 countries receiving funding for mortality surveillance. And we also really had a lot of benefit in terms of the case studies from Mozambique and Sierra Leone, who also participated in this training and provided their experiences as they already were implementing mortality surveillance. And we also saw better collaboration between funders and member states, as well as increased awareness, particularly from the member member state side, getting the policymakers and the leaders to be aware of what mortality surveillance can do and how it can help them. I think I have the last slide, and that is the recommendations that we learned from this experience. Advocacy is important, stakeholder engagement, aligning SRS plans, particularly in this era of SRS planning for the participants online. It is important that these plans are aligned with national priorities and, if possible, embedded within the national planning and budgets for sustainability purposes, as well as building a data use culture to ensure that the systems are able to meet the needs of the users. Lastly, I will acknowledge the different partners and stakeholders that supported us in this work. And with this, I thank you very much. Over to you, Sam.
Thanks so much, Emily. And I encourage people to ask Emily any questions in the chat, or if we get time at the end, we can go back. But thank you so much for this great presentation and introduction to the topic at hand. So without further ado, I'm going to invite Dr. Ivalda to present on behalf of Mozambique's experience with the Global Fund.
Thank you, Sam, and good morning, good afternoon, everyone. So we can move to the next slide, where this is just a summary of the transition from COMSA to SysGov. So we started COMSA in 2017, has a proof of concept that was funded by the MGF, and Mozambique recognizes the importance of this SRS system to generate data on CRVS and causes of death. So we decided that as a country we should own this system and not look at it just as a project. So the transition phase was challenging, and this is something that we need to make sure that we discuss when we're implementing our systems in the different countries. It was challenging to change from the MGF to the Global Fund, but we were after October 2021 successful with the transition, where we are now at our second grant cycle. We were able to receive the GC6 and also the GC7 to implement SysGov. That the changing of the name was also part of the transition in order to have a Portuguese name. So next. These are the guiding principles for the transition from COMSA to SysGov. We recognized that it was important to institutionalize the system as a surveillance system owned and implemented by the government, and the system should respond to the needs of not only the implementers or those that are coordinating the surveillance system, that is the NPHI or INS, but also should respond to the needs of the Ministry of Health, the Ministry of Justice, and also the National Statistics Office and other stakeholders mapped. And we should have a clear vision of responsibilities that includes fundraising and also data ownership. So we have here what the government structure looked like before the transition. When we started in 2017, we had shared responsibilities regarding the implementation or coordination of COMSA, divided within the National Statistics Office that was mainly responsible for the technical operations, and also the linkage with the Ministry of Justice or the CRVS office. And INS or the NPHI was mainly responsible to all the admin and finance management, also the verbal autopsy component, and also the linkage with CHAMS, and also with the Ministry of Health for both the Health Information Systems Department and also the Public Health Department. So post-transition, we decided as a country that we should have one main responsible for implementing the system, and we decided that because of mostly the component related with the causes of death and determinants of deaths, that INS or the National Public Health Institute should be the main responsible for implementing this SRS system and should be doing the linkage with all the stakeholders involved in the implementation of Cisco. So during this, the implementation of COMSA and during the transition phase, we decided to publish 2 papers that were very important to understand the costs of implementing an SRS in the different phases, the startup phase, and also the average annual operating costs, and also how to make sure that the stakeholders are engaged in order to look for additional funding. So those 2 papers are published and are available for all of you that needs to have details on this. But the next slide just shows some details on the costing. For the first table shows what are the startup or the fixed costs to implement an SRS that is mainly around $2 million that are mostly for the infrastructure and all the technology needed to implement an SRS. And we estimated an annual cost of a little bit less than $1 million. So these are some of the details that are needed when we are looking for different funding than the ones that started the implementation. So with this information, we were able to engage with the Ministry of Health. We can go to the next slide. That the Ministry of Health is the main institution responsible to coordinate the Global Fund country proposals. So it was really important to have them engaged in the implementation of COMSA since the beginning in order to convince them that including SRS at this proposal was important to the country. So these are just some of the tools that we used as a country in order to prepare our proposal. So the Global Fund has all the money or the areas related to the 3 main diseases. There are HIV, malaria, and TB, and also has a percentage that each country defines for the resilient and sustainable systems for health that we call RSSH, that are mainly the cross-sectional aspects of for the country. So these are the main tools that we used, not only for the GC7 application, but also the previous one. There is the GC6, and they're also all available online. So going to the RSSH module that we identified has the module that can incorporate an SRS. The RSSH module at the GC7 has 7 main modules, and we identified the monitoring and evaluation systems module that has a component that can support, the Global Fund can support a SRS-VS. And they have a definition of what the Global Fund can support fully, and what the Global Fund can support partially and cannot support. And we can see in the table here that there are a lot of components related to mortality, to community data, to SRS that the Global Fund can support. And it specifies that specifically for SRS, it supports partially. The next slide, it shows how we were able to get the GC6, that this was from 2021 to 2023, where we were able to have an amount for 3 years of around $2 million. It was specifically to develop and interoperate platforms between INS servers and the Ministry of Health server with routine reporting on vital events and cause of death. So this was the objective of the funding during this period. And we were not, the funding was allocated not to INS directly, but to a sub-recipient that was a local NGO in Mozambique, because at that time, INS or the NPHI was not a Global Fund sub-recipient, but for the next grant cycle, that was the GC7 from 2024 from 2026. This is the current funding is now allocated directly to INS. So we are the ones not only coordinating all the operations, but also all the funding, all the financial and admin aspects of this grant. And we have not only the classic RSSH funding to implement for the core activities, but we also have an additional funding from the Global Fund that is related to the emergency preparedness and response that was implemented during the COVID pandemic, that is called C19 for 2024 and 2025, where we decided to leverage the system in order not to collect only mortality and causes of death data, but also to prove that this is a very robust system that can also support disease surveillance. So we have this funding in order to establish an early warning system that supports health emergencies and outbreaks in the country. So this is just an overview of how the GC7, the main Global Fund money goes to. It's mainly for personnel and then to field work. And we try to have to do assessments in order to make sure that the quality of the data is good. So this is just an overview, and it's important to everyone to understand where the money goes to, because the Global Fund, they have a huge concern on sustainability, and it's important to see how we can leverage and reduce costs according to the main lines of the budget. So next, we just share how the financial management structure is, because this money, the Global Fund money, goes to the government. It's a very complex structure, and it's important to each country to take this into account. So the budget is allocated to the Ministry of Finance and then goes to the Ministry of Health. And after that, the money goes to the National Public Health Institute, and this can generate some delays on the disbursement of the funds and can influence on data collection. All the processes, they need to be revised and approved to the Global Fund unit that is at the Ministry of Health. So this also can delay some of the processes, and we have also some of the payments that needs to be revised by the administrative court of the country. So, but we do have monthly meetings with the Global Fund in order to make sure that they monitor the progress of the implementation. So this is just to say that all the payments is made through the government system that is a complex one. What was different from the experience we had at the beginning with the BMGF funding. So next is just the last slide related to the Global Fund experience, that are the main lessons learned, that are mainly that we need to make sure that we negotiate the budget, and the Ministry of Health, that is coordinates the country proposal, understands the needs of the country having an SRS. They need to see it as a priority. They need to make, and we as implementers, we need to make sure that the data is being used for decision making. And there are a lot of challenges related to the government system that needs to be implemented at the institution. There are limitations because this system do not allow specific payments related to field activities. So we need to find other ways of other funding and also personnel payments, specifically when we're talking about community surveillance activists or community health workers that are in a very remote areas. They are not government employees. This is also a challenge to find mechanisms to pay their monthly. So this is what I had to present in regarding Mozambique's experience with the Global Fund. But we do have some additional slides that shows that we do have other funding that we have or we used to have during the last years related. Some of them related specifically to mortality surveillance during the COVID-19 and after that, but also related to other evaluations and also with disease surveillance. So just to show you that how we can leverage the SRS to not only generate additional data, but also to have other funding to support the core activities of the SRS that we are implementing. So thank you.
Thank you so much, Ivalda, and your presentation easily could have been much longer, I know, to get into some of these specifics, but I hope this is a good teaser for most people on kind of what you have encountered and faced, and I encourage everyone to read the articles that Ivalda had mentioned. I put the links in the chat. Without further ado, we're going to invite Dr. Stephen to talk about Zambia's experience with co-funding. Over to you, Stephen.
Thank you very much, Sam, and good morning, good afternoon to everyone on the call. So to begin my presentation, I'll just give a brief overview of Zambia's SRS system, which is known as the SRS-VS, the VS with emphasis on the link to vital statistics. So on the left, that's just a map showing the distribution of the various selected districts of this proposed SRS system in Zambia. Of note is that of about the 20 million inhabitants of the country, this system will have about 6% of that population under surveillance in the SRS. So just a brief overview of the objectives of this system is that one, it will provide nationally and regionally representative mortality statistics. So this is statistics being provided at national level as well as provincial level. And then at national level, this also provides statistics at both for urban and rural stratification. Then a key emphasis for the SRS has been the use of the data that this system will generate at all levels. So this has been incorporated even in the rollout to ensure that even as we train data collectors, there's always a component where we are teaching them how to give back some of the information that will be relevant to the areas where this system will be operating. Then also emphasis on trying to understand some of the social determinants of the causes of death that will be determined by this system through the verbal autopsy. Then key to this has been the linkage of this system right from the get-go with the CRVS system, where we have several mechanisms in place that will link all the vital events captured within this SRS to the CRVS system. So honing in on today's topic, looking at the various funding sources for the SRS in SRS-VS in Zambia, I'll draw your attention to the image on the left, which kind of shows a step-by-step process of how we've approached funding from multiple sources and also coordinating that. So key to being able to get buy-in from several stakeholders who each have different institutional objectives has been engagement really from the get-go. So we had initially received a planning grant from the GATES team, which allowed us to conceptualize and develop a protocol for this SRS. And this process was really stakeholder-driven, anchored by the Zambia National Public Health Institute, but really we had buy-in for several key stakeholders. And during this process, we were able to show the different stakeholders that this system will be able to generate most of the mortality indicators that are required for their day-to-day and programmatic reporting, and really to show them that this system will actually be a better system, generating better statistics than any of the systems that they currently have operating within the country. Once we're able to get this buy-in with the different stakeholders, we then costed the SRS action plan, and based on initial discussions with the Gates Foundation, we had an idea of how much support they would provide towards the establishment as well as the implementation of the SRS. And based on this, we're able to then identify the gap that we needed to fill using resources from different stakeholders. So once we're able to identify what the critical gap was, we then began re-engaging the different stakeholders, trying to see which areas of this budget deficit that they could support, and ensuring that the areas that they would be supporting were aligning with, of course, the SRS objectives, but additionally, each of the institutions' key objectives. So this was the seemingly harder part, but the more difficult part came when we started now getting positive sentiments from the different stakeholders. And so the critical question was, we now have a get-go from these different stakeholders. How do we then coordinate the different disbursements? So this was important because different stakeholders have different fund disbursement cycles. And then we have the implementation plan for the SRS that we had to align with when this funding would be available from the different stakeholders. So even when now the funds were available from the different stakeholders, and we had to also align the different disbursement cycles, the other challenge that we had to overcome was how do we then coordinate, leverage or manage the different administrative challenges that we had to overcome in accessing these funds from the different institutions, because again, different funders have different ways in which funds can be made available and different prerequisites. So on the right, this just shows how the funding for the SRS-VS was spread amongst the different funders in Zambia. And you can see that the Gates Foundation accounted for the vast majority at 75%. And this covers the full implementation as well as setup of the SRS. Then next is the USCDC, from whom we received funding towards the first year of implementation, and based on availability of resources and other considerations, optional or conditional funding in the subsequent years. Then of note was also that through the government buy-in or support through the Zambia National Public Health Institute that supported towards the purchase of some capital equipment for the SRS in Zambia. Then we also had about 2% of the funding towards the SRS, again, mainly support towards capital equipment coming from the Global Fund. So what were some of the lessons learned from being able to obtain funds from different funders? So of course, there were both benefits as well as some of the challenges. I think some of the major benefits included an increased resource pool, in that we're able to quickly close that funding gap that we had identified based on the objectives and the implementation plan for the SRS. Then there's also the concept of risk sharing, where we had support from different funders available, and this allowed us to spread any potential risks across these different funders. Additionally, was the expertise that also came with some of the different funding sources. And this really helped us in implementation, especially towards key human resource, especially from the administrative side, that we were not able to plan for or properly accommodate within the SRS main budget. But because of this shared funding from different funders, we're able to leverage non-technical staff, but rather administrative staff who are working on other projects on these different funding lines to actually help with some of the administrative considerations for the SRS. Again, all this feeds into a stronger stakeholder buy-in towards SRS implementation in the country as stakeholders actively putting in money, and ultimately all this leads towards longer-term sustainability of the project. So some of the biggest challenges that we had encountered with this multi-source funding was trying to align the different funding timelines. This is actually quite crucial because, like I earlier mentioned, different funding from different funders will come available at different times. But then you have an implementation schedule that in most cases you find that you have activities which I can call rate limiting activities that would have to be done before you can move on to the next. So thinking about how you can align the different available funding sources to the project timelines is a very crucial consideration. Another challenge is the multiple or different reporting channels that are funder specific. So you need to align sometimes the same report into different funder specific reporting templates and to ensure that accountability. Then of course, complex coordination across again the different platforms. Next slide. So what are some of the strategies?
Stephen, if you just can wrap it up in the next minute, that'd be great. Sorry.
Okay. So I think one key strategy I can highlight here is flexibility. That is, even as you develop SRS implementation plans, one key attribute that you need to focus on is flexibility. That is, we have to design within those plans some ability to be able to once you have any exogenous shocks towards those independent, the different funders available, some flexibility to be able to continue with the project implementation. Next slide. So in wrapping up, key considerations as you begin to plan out your SRS grants, start small and scale up. So this will help you to navigate the complex funder landscape, learning from yourselves as you go. Again, develop robust implementation strategies. And it's also important to ensure that you have adequate administrative capacity to help you leverage all these different funding requirements, whilst the core team can focus on ensuring the technical deliverables are achieved. And of course, regularly review and adapt funding strategies in line with changing funding landscape. Thank you so much.
Thank you,
and
Stephen.
back to you.
Oh, sorry. I was just going to say thank you for providing these recommendations. I think similarly to the other presentations, there's a lot to unpack here. And hopefully for those of you participating in our upcoming conference, we'll be able to also dive a little bit more deeply into these recommendations and how to apply them. But I'm going to move on to our next presentation, but just to add that I think Dr. Ivalda, you have one question in the chat. Would be helpful to answer. And then moving on, we have two more presentations. I'm going to invite Dr. Philip to present on Vital Strategies perspective and experience with Global Fund support as well. And then we'll have one final presentation from Dr. Daniel. Philip, over to you.
Thanks. And I want to start by expressing my gratitude to the other presenters. This has been an extraordinarily informative session. And I think that those of you who are engaged in SRS planning will really benefit from even re-listening to the recording of the presentations to get insight into how to be successful in mobilizing resources. So first, slide, please. So this is something that everybody knows, that, you know, their CRVS systems are vital for tracking public health outcomes. They provide direct measurement of mortality, including for the 3 conditions that the Global Fund is very interested in. Our Data for Health initiative supports, at the moment, 17 countries, 25 actually, including CDC, to improve their CRVS systems through the Data for Health initiative. And what we did was work with country stakeholders to leverage support, additional support to what we received from Bloomberg Philanthropy, specifically for working on sample verbal autopsy in the context of the CRVS system. Next slide, please. We heard from Emily, there are issues that the Global Fund has identified. And Emily, that little chart that you had on your 2nd or 3rd slide, I hadn't seen before. It's enormously useful. So they've actually specified the areas that they are willing to support within the remit of a sample registration system. And there are other guidelines that are available to calibrate your requests for support for monitoring and evaluation, including something like a sample registration system. Next slide, please. So each country that we supported, that would be Ethiopia, Rwanda, and Tanzania, we approached the CCM, the country coordinating mechanism. Those bodies, the CCMs, have the authority and the ability to follow up regarding the inclusion of M&E and SRS in their proposals to the Global Fund. So the CCM, we found, was a very key body to work with. And in fact, we successfully navigated the CCM structure and process in the support for the 3 countries that are going to be discussed today. These are the only 3 countries we supported, so we haven't failed anywhere, but we've so far been successful for 3 out of 3 countries that wanted to undertake this pursuit of funding. Next slide, please. So we had some resources through the Data for Health initiative to support the establishment of sample verbal autopsy, the scale up to nationally representative samples. Again, this is in the context of CRVS systems, not in a formal sample registration system. But we were successful in raising awareness among the CCM stakeholders and making sure that what we were proposing was aligned with Global Fund strategies. Again, I refer you to the chart in Emily's presentation. There is the opportunity, we received the opportunity from the Global Fund to implement in nationally representative samples. We didn't scale up nationally in any country, I don't think, except Rwanda. And we have demonstrated impact, which I'll get to in the next slide. So in Tanzania, we secured $300,000. And one issue that I want to raise here is that we also included data in our sort of analysis of the major causes of death that the Global Fund is interested in to make sure that we were capturing ICD-coded data in these countries as well to indicate directions of mortality from these 3 causes that complements any verbal autopsy data that is generated. And I would encourage all of you to think about how you can incorporate medically certified deaths that are properly certified through ICD into your thinking about SRS and how to present and communicate findings over. Oh, sorry, not over. Next slide. In Tanzania, you'll notice, and I want to caution you if you use these presentations, when I copied over the tables on the left, I lost all the decimal points. So you'll see absurd percentages. That's because all the decimal points disappeared. So I will redo these tables with the decimal points and ask Sam to circulate an updated presentation so it doesn't look absurd with 356% of, of deaths being among women 5 to 59, according to our verbal autopsy data in HIV/AIDS. So that's just a caveat about the presentation, and sorry for the typos. In terms of the results from Tanzania, well, they suggested that AIDS may benefit from even more home-based follow-up and adherence support, and that palliative care may be an important policy consideration for those over 60 in Tanzania. TB deaths in men were more prevalent among the elderly and adult women. TB in men is the 6th leading cause of death in facility and community data, and mortality among elderly and adult women is more prevalent in community mortality patterns than in facilities. And there also may be a hidden malaria burden among the elderly in the community. And the mortality due to malaria among adults is a controversial area, but our verbal autopsies continuously pick up malaria as a leading cause. And I know that that was a major finding of the Sierra Leone SRS, the hidden burden of malaria among adults in the population. Next slide, please. Again, here in Rwanda, the goal was to scale verbal autopsy nationwide. Rwanda opted not to go for a sample. And we linked VA to the Global Fund reporting needs. Rwanda learned from Tanzania's successes in the Data for Health initiative to leverage Global Fund support. And we developed a compelling concept note for the CCM they bought in. So next slide, please. In Rwanda, we got about $750,000 over 3 years. The system was scaled in 2023. The product so far is over 15,000 VAs. And the broad cause breakdown was the one that is apparent that, there's a major NCD burden. That's not the focus of what the Global Fund is working on, but nevertheless, it highlighted this to government for further investigation. And Rwanda took the step of designating the SRS-VS system, this including not just VA, but MCCD data, as the sole and official source of mortality data in the country. Next slide, please. So these are Rwanda results. Again, no decimal points. There were lots of discrepancies in the ranking of AIDS and malaria as causes in certain age groups between the verbal autopsy and the health facility data. So that's something to consider and unpack. AIDS mortality in the community ranked higher than in facility data. Childhood malaria ranked much more important cause in the community compared with the facility. And this again indicates that more community and home-based services may be required to combat these causes in these age groups. Next slide, please. In Ethiopia, 80% of deaths are unregistered, and there's little data on community causes of death. So far what we have done is piloted 47 Waredas. These are sub-districts, developed training and SOPs and reporting systems, and engaged the CCM for the SRS funding proposal, which was supported. Next, please. So in Ethiopia, they received about $800,000 for 2 years. The VA pilot was very successful, over 1,600 deaths that were analyzed. This was not a representative sample. Nevertheless, again, injuries as a non-communicable cause topped out at the leading set of causes, followed by cardiac issues and stroke. And we had very good data completeness in the VA pilot. Next slide, please. So here again, you see decimal points for a change. So this table copied over correctly. And based on the large sample pilot and the ANACOD-3 analysis, I hope you know what ANACOD-3 is, of ICD-coded facility mortality data, it looks like AIDS, TB, and malaria occur at roughly the same relative proportion in facilities and in the community. And some of them rank fairly highly. AIDS among women, adult women at 6%, the 5th leading cause of death for example, is sort of up there. Also malaria in adults is another signal that we're getting from the verbal autopsy data in Ethiopia. Next, please. So we were obviously strong local engagement of the CCMs is critical. There needs to be a clear demonstration of CRVS relevance to Global Fund. There needs to be a tailored awareness building with CCMs. And barriers, of course, are competing national priorities for resourcing, low awareness of Global Fund about the potential support to CRVS systems. And now, of course, with the closure of USAID, the pie has shrunk considerably for everybody in global health. And there's a risk that funding will go more toward, excuse me, getting critical pills in mouths and shots in arms than it will towards information systems. But I think we can all make the case that we need to know how well we're doing even at that activity in terms of its mortality impact. And this is either SRS or CRVS is crucial to that. So we know that CRVS improvements can enhance health system performance and transparency, or SRS for that matter. And in that regard, countries should engage CCMs early, demonstrate the value of the activities to generating and using local evidence, and align, of course, with Global Fund objectives to make sure that the activity seems relevant to the funder objectives and priorities. Next, please. Asante Sana, and thank you.
Thanks so much, Philip. This was really helpful to see kind of, I think, the breadth and a different perspective on Global Fund from what Dr. Ivalda presented. And again, so much to unpack here, but I think I just will say to all of the presenters, I really appreciate your transparency in these conversations. I think that's how we're gonna all figure out how to kind of tackle these challenges together. And so I look forward to hearing from all of you too around your suggestions for what you want to hear from us next and what would be helpful to help you with your resource mobilization activities. We are over time, so I understand if many of you may need to drop. We'll continue recording, and for those of you who can stay on, we should be done in around 5 to 10 minutes. I apologize for going long. I knew we had a lot to cover today. I'm going to ask Dr. Daniel if he wants to go over his slides on how to plan for resource mobilization quickly, or we can save it for next time, Daniel. It's up to you, and then I'll go into just a quick set of announcements and reminders.
Maybe we can keep it for the next webinar, and we will present it to the teams individually when we are connecting to them, because we are already over time.
Sure thing. Thank you for being flexible. Philip, you have a question before I move on?
Yeah, not a question, just something I forgot. I'm putting in the chat to everyone the link to the Vital Strategies Data for Health Supported Global Grants Program. There should be at least 2 more rounds, I think, in the coming year of the Global Grants Program for countries that are not otherwise supported by Data for Health. And working on SRS or verbal autopsy is certainly within the scope of the kinds of things considered under that program. So please keep a watch out, those of you who haven't received planning grants. Grants can be up to $100,000 to $150,000, so they match the planning grants pretty well in terms of scale. And you should keep an eye out for announcements at the website that I put in the chat. Sorry, Sam.
No, thanks, Philip. That's a great reminder. And I do think we might have 1 or 2 countries that are applicable for that opportunity, but please do look into it. All right, to wrap us up, I'll just say first, big thank you to all of our presenters. That was a lot of content. And again, really appreciate your honesty and transparency in this space. I hope that we can have subsequent conversations around this topic because we know that it's going to continue to remain a struggle and a challenge, and each country.
Yeah. Sam, in 1 minute before
yes.
you say the last word, I have kept a big group of people from the government system in Mali. Sorry, this is Samba. If you just give me 1 second, they are online to just mention that they are here. And that we are working on the form that yourself and Jason instructed us weeks ago. So we couldn't meet the Monday deadline, because we had forgotten that Monday was actually Easter, and then before Easter there have been some off days as well in Mali, and people really started working today. So this whole questionnaire will be fully completed, and shared with the team this coming Thursday. So the team is currently in the room. It's about almost all the representatives from different government sectors, all senior leaders in this room. So I just want to acknowledge their presence and give you one word to thank them for us. So these are really key people for me. That will be very helpful. Thank you.
Thank you, Dr. Samba. And for those of you with Dr. Samba, thank you for joining us for today's session. I think it means a lot for you to be part of this conversation. And I do look forward to hearing your perspectives on resource mobilization as well, for Mali specifically. I think we have some time later this week or today to talk about it as well. So Samba, thank you for joining and for bringing the government officials with you. It's great to have them here and listening. Okay, I'm gonna just switch over to our announcements. So just as a reminder, all webinar slides, the recordings of these webinars, and all planning tools can be found on the JHU Viva website that I've linked to here. Should be an active link if you're looking at the static slides. Similarly, we have a resource library, which will be available online soon. But for now, it's temporarily housed on my Dropbox account, and it includes, just as a reminder, the SRS technical manual that goes over the 12 steps to developing an SRS. Please, if you haven't looked at that manual recently, go back and look at it. It's still a draft, and so we are taking comments on it. If you do see areas where there could be more depth added to it, but for now I think it still remains a really valuable resource for outlining how to approach SRS development. There's also a whole folder in there on just publications of all of the other kind of SRS related activities, including the 2 articles that I shared today are included in that folder. I think it includes upwards of 30 different publications from many different countries and similar experiences kind of in this space. For those of you who are part of the SRS planning grant countries, preparations for our upcoming conference in June are underway. If you have not submitted your nominations for your 10-person team, please do so. We are getting pretty squared away on those plans, and so we want to make sure that we have all attendees kind of notified very soon. And then finally, our next webinar will be on May 19th. Again, we want to hear from you what would be most helpful, but I think we do have a couple of countries that will be ready to present on their situational assessment results from the planning grant countries. We also have some content around thinking about how to integrate mortality surveillance systems and SRS-VS into one cohesive system that we think could be helpful to use this webinar for. And finally, the third topic, either in May or after May, will be on protocol development and preparation for that. So that is all from me. Thank you. Before we officially close up, Philip, I see you have your hand up. Do you want to go ahead?
Yeah, just on your last point about the workshop in June, please note that we have added a day. So it's now going to be June 2nd through 5th. So when you're planning for travel, and your thoughts about that, please factor that in. We're going to be gathering through midday on June 5th. Thank you, Sam.
Yeah, thanks, Philip. And we'll be sending, I believe other communications will be sent out over email with the same information. So look out for that.
Correct.
Great. All right. Thank you all for joining. This was a great turnout. I'm happy to see all of your faces, if not names. And please do reach out if you have suggestions, questions, want to be put in touch with any of the presenters. I'm sure they'd be happy to elaborate on any of their points. Otherwise, I hope to see you all in roughly a month, and we will go from there. So again, thanks for your interest. This has been great, and enjoy the rest of your mornings, afternoons, evenings, and the rest of your week. Thank you. Goodbye.
Thank you.
Bye. Thank you.
Thank you.
Um,
Thank you. Bye-bye.